This is Laura Prolo, and I will be presenting our chapter on Ependymomas by Laura Prolo and Michael Edwards. Ependymoma is the third most common pediatric brain tumor behind astrocytoma and medulloblastoma, with an estimated incidence of 200 new cases per year. Patients who undergo gross total resection have a high likelihood of cure, pointing to the essential role of neurosurgeons have in treatment of children with ependymomas. Standard of care includes gross total resection followed by radiotherapy. Chemotherapy is not typically part of the treatment regimen. Approximately 80 to 90% of ependymomas are located intracranially in children, 1/3 are supratentorial and 2/3 are infratentorial. In contrast, most adult cases occur in the spinal cord. The main reproducible prognostic factor in childhood ependymomas is the extent of tumor resected at surgery. Other variables that have been shown to influence survival are the extent of disease at diagnosis, age of the patient at diagnosis, and tumor location. Current tumor grading systems do not appear to have a major prognostic implication, but more recent molecular classification does influence outcomes. There's no staging system for ependymoma based on the determination of whether leptomeningeal dissemination exists, and it is unclear whether this influences survival. The 5-year progression-free and overall survival rates in children with gross total resection are estimated to be 51 to 75% and 67 to 80% respectively. This is in striking contrast to children with evidence of residual disease on imaging, with a 5-year progression-free and overall survival rates of 9 to 21% and 22 to 47% respectively. Many have advocated repeated resection when there is presence of residual tumor on postoperative imaging. Most intracranial pediatric ependymomas are either WHO grade 2 tumors, classic ependymomas, or WHO grade 3 anaplastic tumors. WHO grade 1 tumors, which are subependymomas and myxopapillary ependymomas, tend to occur in the adult population, and morphologic variants, clear cell, tanocytic, and papillary ependymomas, do not appear to have prognostic implications. Importantly, grade 2 and grade 3 ependymomas may not have major differences in outcome. Recent advances in molecular characterization of ependymomas have identified distinct intracranial groups of ependymomas. Supratentorial ependymomas, and specifically those with markers of neuronal differentiation, have better prognosis than infratentorial ependymomas. With the posterior fossa ependymomas, the group B subtype has a better prognosis than group A tumors. Patients younger than 3 years at time of diagnosis may have a poorer prognosis in older children. Estimated 5-year progression-free and overall survival rates are 12 and 22% respectively for children younger than 3 years, compared with 60 and 75% respectively for children older than 3 years. In general, radiotherapy is not administered to children younger than 3 years old or is given at lower doses and is supplemented by chemotherapy. In a recent prospective children's oncology group trial, following resection, radiation was used to treat all children greater than 1 year old. 5-year progression-free and overall survival in children 1 to 3 years old compared to children 3 to 21 years old was not significantly different, indicating deferring radiation may influence outcome more than age. Ependymomas are slowly growing tumors originating from the ventricular wall or spinal canal. Histologically, they appear as well-delineated, moderately cellular glial tumors with round monomorphic nuclei and salt and pepper speckling of the chromatin. Mitoses are absent or rare. The tumors are characterized by perivascular pseudorosettes, which are groups of cells arranged radially around a blood vessel, and less commonly by true ependymal rosettes. They usually stain positive for glial fibrillary acidic protein, vimentin, and CD56. Ependymomas can be subdivided into 3 types: papillary, clear cell, and tanocytic. Anaplastic ependymomas are malignant gliomas with ependymal differentiation, hypercellularity, nuclear pleomorphism, high mitotic activity, microvascular proliferation, and pseudopallisating necrosis. There are few known familial ependymoma syndromes, and most ependymomas occur sporadically. There's an increased incidence of intramedullary spinal ependymomas in patients with neurofibromatosis type 2, but intracranial ependymomas do not harbor the causative mutation in the NF2 gene on chromosome 22q. Despite this finding, a different tumor suppressor gene on chromosome 22q may be involved with development of ependymomas because there are a few families with increased incidence of ependymomas who do not have the NF2 mutation but have loss of 22q. Patients with Lee-Fermini syndrome due to a germline mutation in p53 tumor suppressor gene have been reported to develop ependymomas. However, the incidence of ependymomas in this patient population is low, and sporadic ependymomas do not typically have a somatic mutation in TP53. Intracranial and spinal ependymomas have been associated with patients diagnosed with multiple endocrine neoplasm type 1 syndrome due mutation in tumor suppressor gene on chromosome 11q13. Charcot's syndrome is the association of colonic neoplasia with central nervous system tumor and is caused by germline mutation in the adenomatous polyposis coli APC gene on chromosome 5. There are scattered case reports in the literature associating Charcot syndrome with multiple ependymomas. Recent advances in molecular profiling of ependymomas have revealed at least 9 distinct subgroups with unique genetic, epigenetic, and transcriptional differences. Initial studies identified supratentorial ependymomas, group A posterior fossa ependymomas, and group B posterior fossa ependymomas, with more recent studies further subdividing supratentorial ependymomas and adding spinal cord ependymomas as well. Thus, each of the 3 anatomical compartments, supratentorial, posterior fossa, and spine, were enriched in subependymoma subtype, in addition to 2 other subgroups per compartment. These molecular subgroups were stable at disease recurrence. These findings provide a reliable and objective measure for subclassifying tumors and potential for altering therapeutic decision-making based on molecular features. These molecular subclassifying should be part of clinical trials in the future. This is a graphical summary of key molecular and clinical characteristics of ependymal tumor subgroups. The schematic represents key genetic and epigenetic findings in the 9 molecular subgroups of ependymal tumors as identified by methylation profiling. This shows that these molecular subgroups are genetically, epigenetically, transcriptionally, demographically, and clinically distinct. Both the posterior fossa group A and the supratentorial RELA subgroups show a dismal outcome with 10-year overall survival rates of 50% and progression-free survival rates of 20%. MRI is essential for diagnosing, management, and follow-up of children with ependymomas. Definition of the pathologic anatomy is critical before surgery to determine both the extent and nature of tumor growth because ependymomas have a propensity to grow out of the foramen of Luschka into the cerebral pontine angle and out the foramen of Magendie into the cervical spine. MRI is also used to plan radiotherapy and to judge the response to subsequent treatments. Surveillance imaging is recommended to identify recurrences early because secondary interventions may improve outcome. Children with ependymomas should have preoperative imaging of the entire neuroaxis because approximately 5% of children have leptomeningeal dissemination at the time of presentation. Postoperative imaging should be done within 48 hours of surgery to assess the extent of resection. After the immediate postoperative imaging, children should have a surveillance MRI every 3 to 6 months for a gross total resection or every 3 months for partial resection during the first year and every 6 months from years 2 to 5, since it is suggested that early detection of recurrence maximizes opportunity for salvage therapies. This is an example of a supratentorial ependymoma. On the left is an axial CT without contrast. In the middle is a sagittal T1 weighted contrast enhanced MR imaging, and on the right is an axial T2 weighted non-contrast MRI in a 3-year-old presenting with headaches and right-sided weakness. Note the extensive calcification within the periventricular tumor. This child was diagnosed by biopsy and was treated with 2 rounds of chemotherapy to decrease the vascularity of the tumor before definitive resection. This is an example of an infratentorial ependymoma. This is a sagittal T1-weighted, contrast-enhanced MRI of a child presenting with headaches, emesis, and gait ataxia. The image is typical of a posterior fossa ependymoma, which have a propensity to grow through the foramen magendae and into the cervical canal. These tumors are also likely to progress through the lateral foramina and grow at the skull base foramina. Children with ependymoma most often present with localized invasive disease. Most recurrences are local, but subarachnoid dissemination occurs rarely and is usually fatal. The surgeon plays the most important role in the treatment of ependymoma because surgery has the greatest effect on the quality and quantity of the patient's future life. Complete resection is more readily achieved in supratentorial tumors and in those that arise from the roof of the fourth ventricle. Gross total resection of tumors that invade the floor of the fourth ventricle or extend through the foramina luschka to involve the lower cranial nerves is much more difficult, and surgical complication rates are higher. Fourth ventricular ependymomas are generally supplied by pica. For surgery, the patient is positioned prone with maximal tolerated flexion so that the floor of the fourth ventricle is sloping away from the surgeon. The use of continuous intraoperative electrophysiologic monitoring, somatosensory evoked potentials, brain sim auditory evoked potentials, and motor evoked potentials, often in association with select cranial nerve monitoring, is initiated. If there is considerable hydrocephalus, ventriculostomy may be placed before opening the posterior fossa. Care should be taken to release CSF slowly so to not precipitate upward herniation or shifts in the tumor with consequent intratumoral hemorrhage. Drastic CSF shifts and lowering of intracranial pressure can also lead to retinal hypoperfusion and retinal infarct. Craniotomy is preferred to craniectomy at our institution because it decreases the incidence of CSF leak and pseudomeningocele formation, as well as incidence of chronic postoperative pain. The presence of a bone flap also facilitates surgery for residual or recurrent ependymoma. The craniotomy should be generous sized to allow easy removal of the tumor. If the tumor is large or extends down into the spinal canal, a C1 laminectomy should also be performed. If the tumor extends rostrally, the bone should be removed up to the level of the torcula without actually exposing the venous sinus to diminish chance of hemorrhage from sinus injury or sinus thrombosis. In all cases, the posterior fossa ependymoma, the foramen magnum should be removed to increase exposure and open up pathways for CSF flow. The dura is open in a standard Y-shaped fashion. Extra care should be taken in the very young children because of the posterior fossa dura can be extremely vascular. Suture ligation of the midline falx dural sinus is preferable to using clips, which may come off and can cause artifact on postoperative MRI. If the dura over the cerebellum is tight, the dura over the upper cervical cord can be incised to allow slow egress of CSF until the dura begins to pulsate to bring down the intracranial pressure. Alternatively, CSF can be withdrawn through a previously placed ventriculostomy. After the dura is open, the cerebellar tonsils are identified and separated to find and follow the posterior inferior cerebellar arteries. The vascular supply to the tumor invariably comes off of the posterior inferior cerebellar artery, distal to the tonsillar loop. Coagulation of large feeders to the tumor from the posterior inferior cerebellar artery greatly reduces the vascularity of the tumor and diminishes intraoperative bleeding. Advancing a TELFA strip along the floor of the fourth ventricle, when possible, will help protect the critical structures during tumor debulking. Attention is then turned to the superior pole of the tumor, defining its margin circumferentially, and then debulking it as it becomes devascularized. This continues until the aqueduct is visualized and open, at which time attention is turned to the inferior pole of the tumor. The inferior pole is dissected along its lateral and posterior margins, taking care not to injure the floor of the fourth ventricle. At this point of the operation, it is often possible to determine whether the tumor is arising from the roof or the floor of the fourth ventricle. If the tumor arises from the roof, complete excision is possible. If the tumor arises from the floor, a portion of the tumor is left on the floor of the ventricle as a thin carpet. The lateral margins of the tumor are dissected out to diminish the tumor's blood supply, followed by debulking of the tumor using either bipolar suction technique or the ultrasonic aspirator. The standard of care for children with non-disseminated ependymoma is post-operative radiotherapy. Although there has not been a randomized controlled trial comparing surgical resection alone to resection with radiotherapy, there are a number of studies demonstrating improved outcomes with radiotherapy compared to historical data. Radiotherapy following resection is standard of care for posterior fossa ependymoma. However, it is acceptable to withhold radiotherapy in children with supratentorial ependymomas if gross total resection with adequate margins has been achieved and the pathology is classical ependymoma. Additionally, radiotherapy may not be necessary in some children after resection of an intramedullary spinal cord ependymoma. A great deal of literature has focused on the danger of radiotherapy in ependymoma patients younger than 3 years old. Strategies to avoid or delay radiotherapy have been proposed in this patient cohort in an attempt to minimize neurological, endocrinologic, and cognitive morbidity. However, a pediatric oncology group study showed that young children with completely resected ependymomas in whom radiotherapy was delayed for 2 years had a worse outcome than those in whom radiotherapy was delayed only 1 year. These results suggest that delaying radiotherapy for the treatment of focal ependymoma of infancy is not advisable. Approximately 5 to 10% of children with ependymoma have disseminated disease at the time of diagnosis. Risk factors for dissemination include younger age, less than gross total resection, high proliferative index, and high-grade histology. For patients with leptomeningeal dissemination, a spinal radiation dose of 36 Gray is recommended. Multiple trials have failed to show benefit of prophylactic craniospinal irradiation in the treatment of localized ependymoma. The role of chemotherapy in the treatment of a childhood ependymoma is unclear. It is not part of the standard care. The response rate of ependymoma to a single agent is roughly 11%, with less than 5% showing a complete response. Of the chemotherapeutic agents tried in the treatment of ependymoma, cisplatin seems to be the most active. In those rare children with ependymoma that respond to chemotherapy, there is no clear increase in survival. Several retrospective reviews fail to show benefit of cytotoxic chemotherapy in the treatment of newly diagnosed ependymoma. Chemotherapy may have a role in avoiding or delaying radiotherapy in children younger than 3 years with intracranial ependymoma. Despite the historically poor response to chemotherapy, there are currently 2 main trials assessing the effectiveness of chemotherapy in ependymomas. In conclusion, ependymoma is a neurosurgical disease with local control being the most important prognostic factor. Failure to observe gross total resection on postoperative imaging should usually precipitate a secondary craniotomy to improve the likelihood of long-term disease control. Radiotherapy should be considered for all children with localized ependymoma. Although chemotherapy currently has little role in the treatment of ependymoma, current molecular profiling defining subgroups of ependymomas offers hope for more effective and less toxic treatment regimens.